Yeah, it's already 9:03. I think we'll start with whatever number of students are here, and then we can just. I'll leave the presentation here so that you can collect it later. Okay, from Mira ma'am. Okay, so good morning, dear students. Today, I think it's a boring topic, quite boring one. I know it used to be boring for me, so I mean, not uh, much things to talk about. It's a topic, osteoporosis, but from exam point of view and in practical life, it is quite important that you should know a little bit about that. So there are lots of technical terms and statistical terms. So I'll just highlight the ones which are really important for you. I mean, there's nothing hard and fast that you should know all of the slides or all of the classifications or all those things. Yeah. So just bear with me. So yeah, okay. As you see on the cover page, I mean the top vertebra. That's if that is the normal vertebra. As you go down, that's the osteoporotic vertebra. You can see lots of widened space there, and as you go down further, there is collapse of the vertebra. So this is a brief overview of what osteoporosis is. So it's basically thinning of the bone, and with reduction in bone mass that leads to pathological, fracture, that's known as osteoporosis. So basically a disease of the elderly and postmenopausal females. So by the end of the lecture, I would expect that you should be at least knowing what is the definition, general definition, as well as the WHO definition, which has a cutoff point according to T-score. So you should be able to differentiate between what is osteoporosis in comparison to osteopenia, other conditions such as osteomalacia, osteoarthritis, etc. So these are entirely different things. Osteoporosis is a quantitative defect, whereas osteomalacia, osteoarthritis, and all those, they are qualitative defects. Okay, just remember that in mind, and we should be able to identify what are the risk factors for osteoporosis and which patients need to undergo screening for osteoporosis and provisional treatment. Yeah. So what are the modalities for diagnosis of osteoporosis? So when you, on the basis of X-ray and bone mineral density, how do you quantify osteoporosis? What do you mean by T-score, Z-score, and treatment? And as I've written in bold, prevention, that's the most important step rather than treating fractures or treating osteoporosis. Okay. So once again here, osteoporosis, so that's first thing is it can be age related, most of the time it is, or it is associated with some other factors that decrease in bone mass. Okay, so it's a basically loss in the mass of the bone. So as you can see in this picture there, in the normal bone, if this much is the bone mass of the mineralized and unmineralized total matrix, so as you grow old or as it is menopause, the ideally the bone mass which should have been around the dotted line is reduced to this much. So that's basically quantitative loss. Okay, so it's a loss in the bone mass leading to clinical features is called osteoporosis. So it affects cortical as well as trabecular bone, cancellous bone. Okay, but I'll come to that later. So as you can understand that it is a loss in total mineralized bone. So it is this portion, this yellow portion on mineralized matrix, that is affected. Okay, so the mechanism is basically by if there is an imbalance when there is a bone breakdown and bone formation. So if the bone breakdown exceeds bone formation, then naturally you will have reduced bone mass. So that's basic pathology there. And the cells responsible are osteoclasts. Okay, so the general definition would be I would appreciate if you could put your comments later on, okay, as we come to the end of the class rather than now. If we run out of time, then I'll request you to log in again so that I'll complete whatever is there in the remaining few minutes there. So the general definition for you to understand, please understand the underlined word. Okay, so it's a systemic skeletal disease. So it's basically a systemic. It affects whole of the bone rather than just one part. It is characterized by low bone mass. Okay, so it's mass which is reduced, mass of the mineralized matrix, and microarchitectural deterioration of the bone tissue. So the bone becomes more hollow there, as you see in the microscope in the subsequent slides. So thereby leading to enhanced bone fragility. Okay, so there's propensity that you'll break the bone easily. Okay, and a consequent increase in fracture risk. So just think about of elderly women, and a young person like yourselves having a same type of fall with the same amount of energy, but the elderly lady is more prone to break her bones more than you, because your bones are quite dense and hers is quite porotic. Okay, so the true definition will be bone with the lower density. Okay, bone lower density as a whole reduces, so there is a consequent fracture risk is high. Okay, so WHO defines that if the T score is less than minus 2.5, then that is a cutoff point for osteoporosis. So as we go on evaluating the BMD, bone mineral density, from 0 to -1, that's normal. From -1 to -2.5, that's osteopenia. And if it is beyond -2.5, lesser than -2.5, then that's established osteoporosis. Okay, so what is this T score, Z score? I'll tell you subsequently. So it's basically very silent. It is, you never know. The patient will be just doing their regular work, and then you won't be knowing that the person has osteoporosis unless the person sustains a low energy fractures or anything like that. Then it gets diagnosed most of the time. So it's quite common, even in our population, although it's more prone in the white population, and in our population also somewhat because of the changing lifestyles and all this comorbidities, risk factors, it's increasing. But in general, it says it affects about 1 million fractures. Just the fractures. Forget about the number of patients; it's quite large. So more than half of female, and around 30 to 45% who are aged more than 50, they definitely have either osteopenia or osteoporosis. Okay, so it's not that it is a rare thing. So it is, eventually if you screen every other person about 50 years of age, then you can actually measure that the patient is having either osteopenia or osteoporosis, and most of them will need treatment. Because there is a significant fracture risk. Okay, so in male, because they are quite outgoing and active, so vertebral fractures are common in male. Okay, so as you fracture a vertebra, the risk of fracturing subsequent vertebrae becomes quite high, up to 20%. That's high. And in vertebral fracture, they are associated with long-term bed riding and associated complications. So it is definitely associated with morbidity and mortality. So just general risk factors. The white people, they are more prone. Africans, for some unknown reasons, they are quite resistant to osteoporosis. Very few of them have osteoporosis, and our Asian population also, they are quite having osteoporosis, even though lesser than as compared to the European or the Westerners. Sedentary lifestyle is another risk factor. A thin person, as well as obesity. It's not only the thin who get osteoporosis. Obese people also have. Both of them are risk factors. Smoking is said to have effect on the bone mineralization, so it definitely leads to osteoporosis, inhibition of the osteoclast. So drinking is another risk factors. One important medicine which you need to remember even for MCQ purposes is phenytoin, anti-epileptic drug that causes osteoporosis. So if anyone, even though the patient is young, is taking phenytoin, you have to think of osteoporosis in the back of your mind and you start appropriate anti-osteoporotic therapy. Okay, so the persons who have low calcium and vitamin D diet, they are also prone for developing osteoporosis. Breastfeeding, yeah, you lose lot of calcium, and then with that feedback mechanism, you lose more and more of calcium, and the bone becomes more weak. Okay, family history is also significant, and premature menopause. Apart from that, these are other factors there. Immobility, if a person is immobile for a long time, bedridden, then there is also a risk for developing osteoporosis. Some metabolic conditions such as hyperthyroidism, hyperparathyroidism, which cause bone resorption, which actually leads to uh, osteoporosis. So just remember that all the metabolic conditions which cause bone breakdown, that is responsible for osteoporosis. Okay, so concomitant steroid use, let's say even for RA, the patients who are taking steroid use for either RA or bronchial asthma or anything, they are also prone to develop osteoporosis. Cushing syndrome, liver and renal diseases, because it impairs vitamin D synthesis. Again, the people with low sun exposures. Okay, people under medications such as phenytoin or heparin. Yeah, and sometimes even malignancy, they present as osteoporosis first, and then as you go on investigation, then you find out that they eventually have either multiple myeloma or some metastasis from somewhere. Okay, so this is again an example of immobility, a patient with long-term bedridden patient developing osteoporosis. So how do you diagnose? I mean, it is usually silent unless the patient presents with some fractures or anything. But then sometimes they can come with multiple compression level fractures, as has been going on for some time, and then with back pain they present, and as you screen, then you see multiple level of compression fractures. Can be either new fractures or old fractures. Sometimes Colles fracture. Most of the time, the fractures around the hip or pelvis or around the humerus, basically the larger bones. So these are the typical sites where you get osteoporotic fractures. The most important ones are the vertebral fractures, distal radius fracture, and the hip fractures. Okay, so broadly it is divided into two types of osteoporosis. The first one is postmenopausal or hormone related. So any postmenopausal lady around her 40s to 50s, so she's a candidate for type 1 osteoporosis. So it affects the trabecular, the cancellous type of the bone more than the cortical, and the sites involved are commonly vertebral and distal radius fractures. So just keep in picture of a post perimenopausal lady around 50 years old, around 50 years, coming with a distal radius Colles fracture, a low energy type of fracture. Then you are bound to give her anti-osteoporotic treatment in addition to treatment for the Colles fracture. Okay. The type 2 is again age related, so that's basically in the older population there, affects both male and female. Okay, so in this condition it's cortical as well as cancellous bone which is affected. Okay, so the manifested usually as hip or pelvic fractures. So yes, we do lab studies, but then they are not much of value, because most of the time it is usually normal, because this is just done so that you are not missing other causes of reduced bone mass, such as you don't want to misdiagnose vitamin D deficiency, or any malignancy, hyperparathyroidism, just overlooking it and thinking it as plain osteoporosis and missing out more serious conditions. So you need to have a baseline investigations such as complete blood count, calcium, phosphorus, vitamin D, alkaline phosphatase, which is a marker of the bone formation, and SGT, SGOT, SGPT, liver enzymes, just to make sure that the liver is okay, kidney is okay. Okay, by doing creatinine, total protein, albumin, etc. Okay, so usually they are normal. So X-ray is not much of value, in diagnosing osteoporosis, because unless you lose a significant amount of bone, more than 30%, it's not evident in X-ray. So it's not the choice of investigation. But then for your knowledge sake, you have to know that, as it is advancing, then you can quantify the severity of osteoporosis through X-rays. So there's this Singh's index. We have discussed it in hip fractures also. So based on that, apparent trabecular pattern on the X-ray, then you can actually quantify how severe the osteoporosis is. So grade 6 being normal and grade 1 being most affected. Okay, no need to memorize all this chart. Just keep something in your mind that there's something called Singh's index, which classifies osteoporosis based on trabeculation pattern in the X-ray. So there's another ultrasound based devices. Okay, these are not accurate. It's a small machine where you put either the distal tibia or the distal radius, those small bones there, and you quantify the amount of bone mineral density. So the only advantage being it is quite fast and inexpensive machine, and being small, it is quite portable. You can take out to camps and all the OPD setting you can do. There's no radiation because it is ultrasound based, very quick to perform and simple and easy to perform. But the fallacies are then it gives quite significant false positive results. So if the technique is not proper, if you are if there is underlying some other conditions such as osteoarthritis or this thing, this tends to misread that as osteoporosis and gives a false positive result. So the only disadvantage is that it is quite inaccurate, so you don't want to treat based on ultrasound based BMD. Okay, and again it is, as I said, observer and site dependent. So one time you do, you get osteoporosis, second time you do, you might just come out normal, and then quite unreliable. So the X-ray based scans, they are the ideal and gold standard investigations for osteoporosis. So there can be single emission X-ray absorptiometry where one single photon is emitted and it scans and gives a picture. It's not very popular. So in order to overcome the shortcomings of this single emission, they have come out with dual energy X-ray and absorptiometry, also known as DEXA scan. Okay, because there are two photons which are coming from the tube, and it's kind of a small CT scanner kind of a machine, a table around the size of the table, and you calibrate, you put the patient there, and it scans your. Usually, it is scanned. The scan is done around the lumbar spine, the neck of the femur area, and sometimes even the wrist or proximal humerus. Those bones are the usual site. So it gives quite good quantification of osteoporosis. So it is quite reliable, and you can start your treatment based on this, and you can follow up how the patient is responding based on DEXA scans. So the usual area are hip and spine. Okay, but disadvantage being it is expensive machine. It's quite bulky machine that you cannot move from place to place, so the portability is lost. It has to be done by a technician. Okay, so it is dependent not on the doctor or clinician. You cannot do that, so you have to rely on somebody. And even though it is a less amount of radiation, it is still a radiating thing. So it's not advised to do repeatedly or expose for a prolonged time, although the radiation dose is a bit small. So as I already told you, there are two photons, so that's why dual energy. Okay, so even though there is minimal radiation, it is still radiation. So it measures the bone mineral density. Okay, so there is this statistical term, T score and Z score. So as you screen that, it gives a value there, and you plot that value in this graph chart. So it's kind of like a road to that you see in that protein energy malnutrition road to health chart. It is also similar to that. So if your dot falls under this green area, you are normal. If your dot falls on this area, it's osteopenia. If it is further down in the red area, it is osteoporosis. Okay, so it is actually an average of all these three sites. Okay, only the 2 or 3 sites are scanned, and the average score is plotted on the this chart. So there is another modality which is CT scan based. Okay, so it's known as quantitative CT scan. So it has quite some advantages because it can be done on large and obese patients which are not fit for DEXA scan. So this is a quite a 3D kind of a picture there, and it allows volumetric measurement. Okay, so and more useful in case of a trabecular bone measurement. So again, useful for type 1 kind of osteoporosis. Okay, the postmenopausal kind of osteoporosis. But the disadvantage being, it is a very expensive, again, dependent on a CT scanner, very large dose of radiation, and it's quite not popular because of its, expense and all those technical issues. It's not routinely done in every center. Bone biopsy, again, just for a completion's sake, we normally don't have to do bone biopsy in order to diagnose bone osteoporosis, but just for a theoretical knowledge, there is some centers to do prefer bone biopsy. Basically, it is to rule out any other pathological causes. I mean, if you are suspecting multiple myeloma or those kind of things, anyway, you have to take out those things, bone biopsies, and then the quite, we can grossly make out that, there is this loss of as you see on the right side of the picture, the quality of the bone is quite, if the trabeculations are large and thinned out thing. So obviously, I mean, this bone is quite dense compared to this one. So, okay. So the density is significantly reduced here. So histological findings will be, again, thinning of the trabeculations, reduced osteons, enlarged Haversian and marrow spaces replaced by fats, and all those changes there. Not really necessary to know. So you need to memorize this chart actually. Just have a look at this. So if a normal person is, the T-score should be -1 to 0. Okay. So if it is less than 0 to -1, then you are normal. So if it is between -1 to -2.5, then that's osteopenia. So it's kind of just a reversible stage and early stage. Okay. So osteoporosis is when the score goes down below -2.5. So -2.5 to 3.5 is grade 1, 3.5 to 4.5 is grade 2. Again, you go on grading like that. Okay. Again, the same chart here. Normal within one standard dimension of a young normal. T-score is basically you are comparing your score with an ideal population. Let's say a young, if you are comparing a male patient, you are comparing his bone quality with bone quality of a young 35-year-old male. Okay, if it is a female, young 35-year-old female. But Z-score is you are comparing to the same age. If you are doing scan of a 60 years old, you are comparing to a 60-year-old healthy person, then that becomes a Z score. So Z score is not popularly used in BMD. So you need to know about in reference to T score. Z score does not matter that much. T score matters. Okay. So again, between -1 to -2.5 is osteopenia. Less than -2.5 is osteoporosis, and as you go down with subsequent risk factors, you classify as osteoporosis grade 1, grade 2, grade 3. Okay. So again talking about this BMD results, because this is important that you should know, quite straightforward that where your dot falls, you can classify either it as. So we have 10 minutes. Okay, I think if we finish it, if it gets cut off in between, I request you to log in again. Okay. So basically, this dot plots you where you fall. So as your score increases, there is a quite high chances that you have this fracture risk. So I mean, the software itself gives you what percentage you are probable to have a fracture. So that's the cumulative fracture risk and all those. They are calculated by the software. So I mean, there's no need that you should be knowing all that. Just know that T score and Z score. T score is the standard deviation of the BMD, comparing you with the average healthy 35-year-old sex matched population. So if it is a if I'm doing a scan of a 60-year-old man, I would be comparing that with the ideal bone of a 35-year-old healthy male person. Okay, if it is a female, comparing with female. So it's basically comparing with a healthy standard. And Z score is actually compared to your age match control. So if you are a patient of 60 years old, you are again comparing it with a bone quality of a healthy 60-year-old. Okay, not the ideal population. So you always want to compare with the ideal population, which is the T score. Okay, so just remember WHO has this cutoff limit as minus 2.5 as a cutoff for osteoporosis. So if you go below minus 2.5, then that is osteoporosis. Anything above that up to minus 1 is osteopenia, and anything above that is normal. I mean 0 to minus 1 would be normal. So basically the management goal is to prevent fractures. Treating is not that important modality, although I mean if it happens then you have to treat anyhow, but then this is largely preventable thing, so you should focus on preventive aspects rather than treating. So the treatment goal would be either three mechanisms: either you have to reduce bone loss, or you have to stop the loss, ongoing loss, or you have to increase the bone gain. Either three of the simple mechanisms. Okay, so reducing bone loss would be by giving bisphosphonates, and I'll show you in the later pictures. You can stop the ongoing loss by supplementing calcium, vitamin D, again this calcitonin, giving some kind of physical exercises, and this hormone replacement therapies, selective estrogen receptor modulators, and all those things there. And increase bone gain by giving fluoride. Fluoride, as I told you, in a double-edged sword. If you give more fluoride, then your bones become brittle. So just worthwhile to note this, anti-osteoporotic agents. So basically, the first thing simple would be calcium and vitamin D supplementation, which is mandatory for every postmenopausal lady and every elderly having fracture risk or any past history of fracture. Okay, fluoride. So it acts by inhibiting bone resorption, but you don't want to give it excessively because there are associated toxicities. So fluoride is not routinely used as anti-osteoporotic agents, but just bear in mind that fluoride is also an anti-osteoporotic agent. Okay, calcitonin is again given to stimulate your your calcium homeostasis mechanism. So just so that you speed up production of the stimulate osteoblast and lay down more bone. Bisphosphonates, they such as alendronate, ibandronate, residronate, zoledronic acid. There are long 4 generations of this bisphosphonates. So they basically act by inhibiting the osteoclasts. Okay, so the osteoblast activity is reduced so that there is less and less of bone resorption. And you can supplement estrogen replacement therapy in postmenopausal ladies, selective estrogen receptor modulators, or parathyroid hormones as treatment. Okay, so exercising is even effective in osteoporosis, especially in type 2 old age people. So a small amount of yoga or physical activity that makes the bone bit stronger, and the form of a treatment for ongoing osteoporosis as well. So the prophylaxis should be given for at-risk people for osteoporosis, as I told you earlier. Any postmenopausal lady or any elderly with low energy fractures, they are at risk people. So you should be supplementing them with all these anti-osteoporotic treatment. Okay, they should be taking diet with adequate calcium intake, and people with hormone replacement therapy. So these are the diet which is rich in vitamin D, just as milk products, the beans, mushrooms, salmon, cheese, eggs, and we can even supplement them with orally taking calcium formulations and oral vitamin D supplementations there. So the people who are at malabsorption, such as ulcerative colitis, Crohn's disease, they are quite at risk, even though they are young. And people with renal failure, liver cirrhosis, those are at high risk, even though irrespective of the age. Okay, so the normal intake would be, you should be supplementing at least 1000 milligrams of calcium. So I think more than half of us are still calcium deficient because of our diet is not everyday diet does not contain that much of calcium. So our part of the population actually needs more supplementation in form of tablets and all those things in addition to diet. Okay, so there is another agent, calcitonin, which comes in injectable as well as nasal spray form. So it is derived from the fish salmon. Okay, so that's the name, salmon cal. So it is also effective in treating osteoporosis. So either taken nasally or injectably. But then the issue with this is that it can cause hypersensitivity reactions, and it takes a long time to show its effect. So these are the quite popular ones, bisphosphonates, which are routinely used for treating osteoporosis. So you need to know a few of the names which are important in clinical practice as well as for your future. So the basic mechanism is by decreasing bone resorption. So it binds to osteoclasts. Okay, so that's osteoclasts as a whole, they are not destroyed, but the process of bone what do you call that, excavation, that is being done by the ruffled membrane in the hausiplakine, that is being affected. So it reduces the rate of the excavation done by the osteoclasts. So the oral forms would be alendronate, residronate. They are prescribed once a week. It usually comes in a strength of 70 milligrams. So that's advised to give once in a week time for maybe about 12 weeks and respond how the and see how the response is. Okay. So the another injectable form which we commonly use is zoledronic acid. Okay. So palmidronate, even though it is there, it's not commercially available in Nepal. We use zoledronic acid. So this is usually given because it gives quite early results, and there is better compliance because you don't need to take it repeatedly in a week's time or so. It's a once a year dose. Okay, if you give it for 1 year, then it's likely that patient will comply to it much better than oral forms. And there's also ibandronate, bone care by the trade name. It can be given once in a month. But the only disadvantages with bisphosphonate is that you have to remember these two side effects with bisphosphonates. They can present with osteonecrosis of the jaw, and there are reports that patient present with idiopathic subtrochanteric fracture of femur there. So that is one unique peculiarity or disadvantage of using bisphosphonates. But they argue that it is only seen in people with underlying significant dental diseases and IB formulations. But you have to be aware that the risk of taking bisphosphonates is that you can either have osteonecrosis of the jaw or subtrochanteric fracture of the femur. Okay, so you have to screen the patient for the creatinine clearance using the Cockcroft Gault formula. So where you take into account the patient's BMI, the creatinine level, and there's this formula. So you if it is only more than 125 millimeter. Any questions in the meantime you can ask? I know this is a boring topic, but there's no choice. You have to know something. I tried to make it as interesting as possible, but this is how far you can make it interesting. Any questions? Okay. Yeah. Samir, I've got a good question from Samir. Okay. So it is, why it is called quantitative when the quality of the bone is reduced by being porous? Yes. That's also what I used to think, the quality of the bone that is being reduced, but you are not measuring the quality by BMD. So you are measuring the bone mass, bone density. So that's something physical. So because you are interpreting on that basis, you are expressing that in terms of the bone mineral density, which is a quantitative thing, because you are measuring something, the bone mass, rather than you are, because the machines, they are not measuring the quality of the bone. The quality of the bone is measured, assessed by you, as you know, as you drill the bone. It is, if it is quite soft, then that is the quality of the bone. Or if you look into the microscope, then you can see, the trabeculations, that's quite wide trabeculations and quite porotic bone. So that is something physical, but you cannot quantify that. So what you are quantifying is basically based on measurement of the machine, which calculates the bone density and bone mass. So as per the definition, this is called quantitative disease, quantitative measurement rather than qualitative measurement. Okay, Samir, have I answered your question? Okay, good. Abhinay Cockcroft-Gault formula is a long formula. I can't recall it now, but then it basically takes into, BMI, your creatine clearance and all that. You can just search anywhere. It is usually in your pharmacology topic there. Okay, so if you want, I can send the link, or you can find it yourself, but not that you should know it by heart, but before formulating, then you can just uh, what I do is, like, I take the app, we feed in the data, and it gives me the value, so I don't remember that for my daily purpose. Okay, Abhinay, any other questions? Okay, shall we start? Okay, so disadvantages, just those two important side effects of bisphosphonates you have to know. And if you give that in patient with compromised creatine clearance, then you end up the patient taking into renal failure. So which is one important thing that you need to keep in mind. Okay, so do not give it to patients who are having reduced creatine clearance, and it's expensive, of course. Osteoporosis, estrogen, role of estrogen replacement is basically aim to reduce bone resorption. So, try to supplement estrogen in menopausal ladies there. But, with these ongoing issues of increasing cardiac risk, increasing, that is thromboembolism, and even reported incidences of risk cancer, so it is not routinely prescribed unless the patient is having severe postmenopausal symptoms, like, hot flushes, mood swings, and all those issues. Denosumab is, a thing which is quite popular in Western countries, but not in our setup, unfortunately, because of the cost issues. It is very expensive, because it is a monoclonal antibody to RANK, receptor associated natural killer ligand, so which has a role in this osteoclastic, the inhibitory loop mechanism there. Okay, so so this target is to reduce the formation of active osteoclasts. So you are reducing the number of osteoclasts, and thereby reducing the bone turnover. Okay, so it's given in subcutaneous. Again, joint osteonecrosis is reported. You don't need to know the dose and side effects. Just be aware that there's an agent, monoclonal antibody known as Denosumab. Okay, again, BMP, bone morphogenic protein, they are again very expensive kind of things. So they lead to maturation of osteoblasts. So hereby you are promoting osteoblasts. You want them to mature early, so that it lays down more and more bone. So you basically aim to lay down more bone than what is lost. Okay, teriparatide, again a very expensive thing that is used, but only when it is, severely osteoporotic, and when the patient is capable enough to afford this molecule. So it is given in a subcutaneous daily injections dose of around 20 micrograms. It's very, very expensive. Maybe one shot of injections costs you around 10-12,000 Nepali rupees. So just you can imagine it goes on for months. So at least 8 to 10 lakhs you would be spending on teriparatide if you are using it. So rarely used, depends on affordability of the patients, but this definitely has a proven advantage that this is the only agent which has truly anabolic effects on the bone. So I mean the results are quite predictable with teriparatide. Okay, again, selective estrogen receptor modulators known as Raloxifene. They have anti-resorptive effects comparable to estrogens, yeah, but they are not much used because again of its side effects such as edema, cramps, hot flushes, and there's a high risk in increased chances of venous thromboembolism, so not routinely used. So now coming to surgical management of osteoporosis, you should know these two terms, vertebroplasty and kyphoplasty. So vertebroplasty is basically when you have a painful bone because of this compression fracture. Okay, so this collapsed vertebra is there and there is this pain. So what you do is you drill down through this pedicle in CM guidance there, put in an injection there, and you inject bone cement, PMMA. Okay, so basically you leave the shape of the vertebra as such, but you are filling the cavity with the bone just to strengthen it, so that it gives you pain relief as well as some strength to the bone. You are not restoring the vertebral height. So if you go to restore the vertebral height, that is known as kyphoplasty. Okay, so that's the basic difference between vertebroplasty is basically done just to strengthen the bone by injecting bone cement in the collapsed bone, whereas in kyphoplasty you first inflate the balloon to restore the vertebral height, and in that cavity you inject the bone cement. So your aim is to restore the vertebral height and thereby improve kyphosis and pain. Okay, so these are basically done for intractable pain which has failed to respond to conservative management. And if you are suspecting some bony metastasis and osteolytic lesion, at the same time you can just go through the pedicle, take the tissues for biopsy, and at the same time you can just inject the bone cement just to give the patient a bone relief from the pain. So it should not be done in any patients with bleeding disorder. If there are any chances of improving with conservative treatment, you should do that first rather than taking it to this invasive procedure. Okay, if the patient is asymptomatic, silent kind of a vertebra, you don't want to do unnecessary vertebroplasty or kyphoplasty. If there is again local or generalized infection around the area, and if the patient is allergic to bone cement, and if there is a spinal canal involvement, or neurological compromise, then your vertebroplasty and kyphoplasty is not going to help. So you need to have another procedures. So the aim should be, how to reduce the fracture incidences, how to reduce falls, how to reduce, injuries rather than letting it happen and treating it. Okay, so there are these things known as trochanteric pads, which are worn in the undergarments of elderly people. So even if they slip, it acts as a cushion just so that you don't want to break it very easily there. So that is being used in elderly population, and even the newer ones, they say they are having some airbag kind of a self-inflatable device that is ongoing, but then not very popular. So basically you should treat underlying osteoporosis. Okay, so you want to screen the patient by DEXA scan, you want to follow up the patient by giving anti-osteoporotic treatment and see rescan in again 6 months time and see how the score has improved or not. Okay, so that's your first priority. The second modality would be to reduce the risk of the break using all these devices, fancy devices there, and you can avoid the risk of fall by if person leaving elderly people there, you can have proper lighting there, you can have some steel railings, some anything that use of crutches or walking sticks just to make them stable, and avoid slippery floors on the stairs or in the bathroom. or in the even in the floor. So you want to do everything to prevent the risk of fall. So this is also one very important aspect in treatment of osteoporotic fractures. Okay, you don't want to cause the fractures in the first place rather than treating it. So how to screen and who to screen? So you should screen all women more than 65-year-old, men around 65-70. If it is perimenopausal lady with risk factors, you should screen them. I mean, let's say if it is a perimenopausal lady, obese kind of a lady who's sedentary and having back pain and all those things, so she's an at-risk patient, so you should screen them. Okay, so if the patient is on steroids or on any anti-estrogen, anti-testosterone treatment for their underlying problem, then you should have a high index of suspicion that these people can develop osteoporosis, so you want to treat them. Okay, so basically you want to supplement them with calcium, vitamin D. There's no harm in supplementing every patient with calcium, vitamin D, because whatever is excess, that will just go down through stools. Okay, so you should encourage them to do some weight bearing exercises such as light running, jogging, or kind of a low energy activities there, or yoga. So DEXA is a very important screening tool. Okay, so you should start therapy on patients with low impact fractures, such as if the lady comes with a Colles fracture, you treat the Colles fracture first by applying plaster or doing plating, but then as the wound heals, you also you want to keep in back of the mind that the underlying cause is osteoporosis. So if you don't treat osteoporosis, she'll land up again in a couple of years again with another fracture. So you want to treat osteoporosis there by supplementing calcium, vitamin D, as well as anti-osteoporotic treatment like bisphosphonates. Who needs treatment? So any lady above 65-year-old or any younger postmenopausal woman, or let's say if any lady who has undergone total hysterectomy with oophorectomy in 30-35 years because of some other conditions such as ovarian cyst or whatever, you want to supplement that patient with anti-osteoporotic treatment even though she is 35. Okay, so age is not only the factor. So age is one thing, but you have to see. So any patients with T-score less than -2 will need treatment. Okay, without risk factor. But even if it is, if there is any prior vertebral fracture, hip fractures, or even distal radius fracture, but the score is less than -1.5. Let's say if the patient score comes out osteopenia, but she has osteoporotic kind of a fracture, so let's say distal radius fracture, then you want to treat that patient because the subsequent risk of fracture is quite high. Okay, so this is the last slide for you. So I want you to go home with this message. It's a silent disease. It's not manifested. It's not manifested in any clinical features there. Okay, but it becomes manifest when the patient presents with low energy fractures there. So, and it is, trust me, it is in large magnitude. If you screen 2 people out of 4, then 2 people will be having osteoporosis. Okay, even though they are asymptomatic. So it's a quite largely a preventable condition and treatable. Largely a preventable and treatable conditions. You can treat the patient because actually before coming with fractures, if you are able to diagnose it early. Okay, so but this is largely overlooked in our population. So you need to keep in back of the mind with any lady, any postmenopausal lady, any osteoporotic fracture, that you have to underlying cause is osteoporosis. Okay, so the prevention of osteoporosis, prevention of falls, prevention of is more important rather than treating. Okay, so I hope by now you know this WHO definition and what DEXA scan looks like, what do you mean by T-score and Z-score. Okay, so I hope you enjoy this sunlight, and wishing you happy Dasai to all of you. I think my next class will be after Dasai. So Hari Shrestha, Hari, I appreciate if you could write your questions in English, okay? But then I'll answer it. Osteoporotic patient ma fracture bhaye fracture recovery huna garo huncha? Not necessarily, Hari, because osteoporotic patient, their fractures is there, but the fracture healing is not affected. The fracture healing is just like that. So the fracture healing is not slowed down in osteoporosis. That is one good question. So only the quality of the bone, the bone mass is compromised. The bone is porotic. If you want to drill the patient, if you want to put the plate on that patient, so it's quite unlikely that the screw will hold on to osteoporotic bone and those kind of things. But healing is not affected by osteoporosis. Okay, just that is one important thing to keep in your mind. Okay, so again, quality, it's more than quantity. Okay, it's a quantitative bone loss of a mineralized bone matrix. Okay, type 1 is postmenopausal, type 2 is age related. Okay, affecting cortical and cancellous bone. Type 1 affects cancellous bone only. Healing is not affected, the fracture healing is not affected in osteoporosis, but only the surgical qualities, the screw holding capacity, all those things are affected, but fracture healing per se is not affected. Have I answered your question, Hari? Any other questions? 1 minute, then we'll leave the class. Okay. Okay, I think we'll see you after the same.